conferences. We really appreciate you coming. Sorry it's so early, but you're a surgeon. Late in the day, right?
Yeah. My team's not here because they're all in the OR. So.
Yeah. So we're so blessed to have her as part of our team for us in radiology. We always have great cases that she explains what we're seeing. But differences in sexual development, I think, is particularly a very confusing set of that we struggle with all the time, and it's just been wonderful for you to be here and to work on the DSD clinic. And I think we're really one of the leaders now with your
so we're we'll talk a little bit about the DSD TRN, but we have a team here that, a multidisciplinary team that sees these kids, so we definitely want to continue to see them. And Hansel has been helping with the, so he's been amazing. It's been great. So the name, the official name is Disorders of Sex Development. That's what they came up with in 2005 when they came up with the consensus guidelines, and I'll go through some of the history. A lot of the advocates are very offended by the word disorders, so differences of development is what people are starting to use now, and I think it makes sense. I feel very comfortable with that, so that's why I made that the title. So I'm going to the case that we had here. 4-year-old woman, G2, P1 at 20 weeks, that Meg's first trimester screen was abnormal, and she on a CVS, which is trisomy 22 mosaicism, 46XY, and then an amniocentesis in the second trimester, which was 46XY, and there was no evidence of trisomy 22 cell, which was 4N. She had a previous daughter that was 2 years old and healthy, and was from Ethiopia, had no consanguinity or other family history. And here's the ultrasound. I have to apologize. This was not the original ultrasound. This was the ultrasound at 28 weeks. But the ultrasound at in the trimester showed a small scrotal sac with line cleft to suggest labial formation, but a small phallus and possible hypospadias. Any thoughts? The tulip sign there. For the differential diagnosis at that time, we have a baby that's 46XY with a possibility of ambiguous genitalia. Sorry, the differential in just a second, but basically we through a detailed way. But basically, either the gonad has not developed, which are gonadal dysgenesis, complete dysgenesis, or testicular regression, where it formed for a little while and then stopped working, or disorders of androgen synthesis or action. So the gonad's not making androgens, or there's androgen insensitivity, or there's androgen cannot be converted to DHT, which is what's active. And I'll go through the whole. So here's actually the differential that came out of the consensus guidelines. So 46XY DSD, you can have gonadal development, androgen action, and there's a whole list of slew of things with 7-hydroxysteroid dehydrogenase being more common as we do this in the DSD TRN, some of these other syndromes, and then androgen insensitivity, which is actually quite common. That's been one of the biggest things that we're seeing of. And then you can have other things, veining testes, isolated hypospadias, hypogonic hypogonadism, hypogonadotropic hypogonadism, which is congenital. So I guess that answers the question. The pituitary is active in utero, and cloacal issues. The workup that we did, and actually Meg ordered it, was a microarray, which came out abnormal for the androgen receptor, partial deletion of the receptor gene and complete lack of amplification of the 3' end of exon 1. So this was suggestive of a large deletion and a severe deletion rearrangement. So this androgen insensitivity, which was really concerning because most of the androgen sensitivity we see is complete androgen insensitivity. Those are really easy to manage. They have female genitalia, they have female gender identity, no problems. This was an ambiguous baby, and that made it much more difficult to figure out the gender, and there's changes that happen as they go through puberty. So we had pretty long conversations with this family. They considered termination. They actually went to the site for trimesters termination, and there were protesters outside, and they changed their mind. And came back, and at 28 weeks had this ultrasound that we saw before. It was even more concern for us.
So just the sequence, the break came back before you saw the tulip sign?
Well, we knew there was abnormal looking genitalia, but then the follow-up ultrasound was even more abnormal, so we were very, very concerned about it at that point. And so this is the 28-week ultrasound, consistent with partial androgen insensitivity, no hydronephrosis, and we were not able to identify Müllerian structures. At this point, I'd spoken to Dr. a couple times about could they see a uterus in there, and the plan was just to see the baby postpartum. Baby uncomplicated full-term delivery, and the neonatology evaluation was that there was micropenis and bifid scrotum. When we saw this kid, there was a 90-degree curvature, but the phallus was actually 2.5 centimeters, which is pretty good length, and a penoscrotal transposition with forameatum scrotal to penoscrotal and a palpable left testes. I think on ultrasound we found the other testes. So this really looked like a severe hypospadias rather than really truly very ambiguous looking genitalia. And I think we were all a little bit relieved because it looked fairly male genitalia. Hans felt that this could be something that could be taken care of in a 2-stage procedure. I'm not sure if he's done the first stage yet. This baby is now probably a year old. But it was quite a relief because we felt that with this much testosterone exposure, the baby would probably have male gender identity. The genitalia looked fairly male, although I have to be very cautious because the hypospadias repairs have a very high chance of breakdown, and many of these patients end up having many surgeries and have a lot of difficulties. And the hypospadias epispadias group part of the DSD tier and does a lot of advocacy because they have a lot to do. So I don't want to belittle this because I think the urologists are like, this is easy, it's hypospadias, but I think this case really made us think, how many of our hypospadias we looked. We do about 150 hypospadias cases in this institution. How many of those are actually a genetic abnormality? And what I'd be really interested in is getting some funding and doing some testing on all of them, but at this point, we just haven't gotten that organized. So this is, the plan was hypospadias repair after 6 months, and my guess is Hans has already done the first step of this. So the history of, we used to use the word hermaphrodite until 2005. Hermaphroditus was the son of Hermes and Aphrodite, and the nymph Salamassus fell in love with him and merged him, and you can see these Greek and Roman statues that show these both female and male genitals. And the history of intersex is really interesting. There were a lot of case studies from the 1500s to the 1900s in Europe, but the most famous is this Abel Barbin. In 1968, he committed suicide. He was raised as a female, and then came from a very poor background, went to a private school, had multiple relationships with women, and then switched to male gender, had been examined by a doctor earlier in life who noted ambiguity, but when he committed suicide, a physician came up to actually noted his physical findings and actually wrote it up. And he had written and so the Intersex, people consider themselves intersex, celebrate his birthday as the day. So very interesting. In the 1900s, we used to think that true sex was related to the gonads, and then we started learning about genetics, and everybody thought genetics was everything, and I think that there's a problem between both of those, and I think we need to be very careful. I mean, I've had doctors here say, well, the baby's XX, why are they raising the baby as a boy? So we need to be very careful. I don't need to tell you guys that. In the 1960s, there was Money, who was at Hopkins, said that gender identity was really learned, and his famous case is this John Doe case. So it was twins, and one of the twins had a botched circumcision, and they decided to convert the twin into a girl. They did this gender change at like 18 months. His theory was that if you did it before 2 years, the child would be okay as far as gender identity, and he reported this as a success. And Diamond, who was one of his students, actually followed up on this. The story was actually not a success. This kid went through, got to pubertal time, and was issues and was told what happened, and at that point immediately switched to male gender and then committed suicide. We have a couple of cases at this institution of cloacal patients, so these who had no penis because of cloaca. I have one right now who's been raised as a girl who doesn't know the story, who's 10 years old and still has testes in situ. So we have a mess in our hands there. So in the 1990s, the Intersex Society of America was founded, I think, through a lot of advocacy of the groups and to raise awareness of these issues and to advocate. And in 2005, a bunch of people met in Chicago and had this meeting, and that's when they came out with this very strong consensus and changed the nomenclature of everything. And the Intersex Society went away at that point, and then the Accord Alliance started after that point as the advocacy group. But just to give you the background. So this was what they said. We should use the word intersex anymore. We should use DSD. And again, a lot of people are very uncomfortable with the disorder wording, but a lot of patients still identify themselves as intersex. You may see patients who say, I'm intersex, and other people are very offended by this word. We used to say mixed pseudo hermaphrodite, so that was under virilization of an XY male, not XY DSD, female pseudo-hermaphrodite or over-virilization of a female for XX DSD. You can see that it's just a lot cleaner. And what we used to call true hermaphrodite is now called Ovo Testicular DSD, and so forth. And it came up, big miss there, sorry about that. So basically, the gonads affect the internal organs. If androgen hormone is produced, then have development of the epididymis and the vas deferens. If there's no anti-Mullerian hormone, by default it goes to a female, and that will form the uterus and the cervix and the upper part of the vagina. The big factor here seems to be SRY gene. So if you don't have the SRY gene, you develop into a female, both internal and external. Your gonads develop into ovaries. There seems to be some gene that probably causes ovaries to differentiate, but really that seems to be the default. But if you have SRY, then you have differentiation of the gonad, and the Sertoli cells develop. The Sertoli cells produce the Mullerian inhibiting factor, which causes the uterine structures to go away. The live cells form, they create testosterone, which causes some of the internal ducts to form. Then the testosterone is converted to DHT in the cell level, and that causes the external genitalia to form. So whenever you're thinking of these cases, something can go wrong at each point, right? You can have no SY gene, or you can have no gonad. You can have no Sertoli cells, or you can have no Leydig cells, or you can have testosterone that doesn't change to DHT. Does that make sense? So I would just divide it up. The two cells make different hormones. The three hormones you need to know are Mullerian inhibiting factor, or AMH, testosterone, and DHT. Just how the areas that are the areas that develop into the labia would develop into the scrotum under the influence of testosterone. The phallus grows under the influence of testosterone, and how these areas correspond to each other. And this is called the Prader Classification. It's used for girls with CA, and it's just how virilization there is, and they came up with a staging system. people use and some don't, but it's an easy way to just describe something. So the baby that we had actually was probably a stage 4, even though this was not a girl, it was an X, it was not an XX, so there was no uterus and vagina. It looked like a stage 4 around there. The statement came out with just these 3 categories. There's sex chromosome DSD, so those are your chromosomal abnormalities. So then there's 46XY DSD and the 46XX DSD. So sex chromosomes, the classics are your Klinefelters, your Turners, but I do want to mention the 45X, 46XY because I think that's the biggest that we see is that, which is really interesting. We've had complete phenotypic Turner girls, and that picture down there is one of our Turner girls that we did a gonadectomy on, who actually happened to have gonadoblastomas already at that age, at 8 years old. We've had complete male. We recently had a complete male that was picked up just on free DNA. It was picked up that there was an X, and so then underwent all this workup, and they found out that this baby had this, but completely normal male. So obviously those gonads were working. So when we're talking about gonad versus genes, and then our really ambiguous, hard to figure out cases have all been 45X, 46XY so far, most of them. Then the 46Y DSD, and there's the issues of gonadal development. So that's the first ones. And if you look, this is an old table from one of our textbooks, but it's really useful because it shows where each hormone happens. So depending on when the gonads die, you get different things. So if they die very early or they never form, you get what's called Swyer syndrome, and it's completely female, internal organs are female. But it happens in fetal life. You're going to have someone who has no structure, has Wolffian structures, but the external genitalia is ambiguous. And those regressions are associated with genetic issues. So here it's just in a table form. Again, if it happens after fertilization, you get complete female, but if it happens later, you have ambiguous, and then you may have infantile if it happens even later. And related to these genetic issues, your WIT1 and your Fraser syndrome. The second one is the disorders of androgen synthesis. And, you know, this is androgen synthesis. It's not the 17-hydroxysteroid is the biggest one. That's where there's a blockage at the adrenal and you just can't make testosterone, and so we have some of those. This is the famous one, the 5-alpha-reductase. Everybody's heard of it because of this book, Little Sex. It's when you cannot convert testosterone to dihydrotestosterone. So you're going to make testosterone, so it's not really a synthesis, but it's an action. You cannot convert it to dihydrotestosterone. The families that were described was in the Dominican Republic, and they converted from female to male at puberty. It's an autosomal recessive gene, and we can test for this in utero. Very rare and very difficult to manage. We have a teenager right now who was discovered because of lack of puberty or contrasexual puberty, and we've been having a hard time dealing with this family. There is actually androgen action. So this is your androgen insensitivity syndrome, which is X-linked. They almost 100% of the time gender identity of female. I put both pictures here because the first picture on the left is how we used to picture these people, and this is one of the things that advocates find very, very offensive. On the right, this is Arlene Baratz. She has 2 daughters with androgen insensitivity. One of the daughters is pictured here, and she started a group called the DSD, and has really been a huge advocate for these patients. There is this known risk of gonadal tumor. However, the risk is very low, and the types of tumors they get are very benign behaving. And so it's actually interesting that it's been through some consciousness raising by who happens to be a radiologist, by the way, that doctors are second guessing whether they should really be taking these gonads out now. But so that's our biggest goal. For example, we had a baby who was born with bilateral hernias at birth, ultrasound, they found testes in the inguinal canals, and we needed the hernias. We weren't sure whether to take the gonads out or not, and really had to wait until we got this test result back to see if it was complete androgen insensitivity, because if it was, we would not have removed the gonads. As it was, the hernias got worse, and we didn't have the results back yet, and so we repaired the hernias, that's outside the inguinal canal, which I disagreed with, but we'll get to that as we grow in this field. But the test did come back complete androgen insensitivity. So this is common. When
the gonads are now in the
they're in the inguinal canal.
Oh my goodness.
For the 46XX, you can have Ovo Testicular DSD, Testicular DSD, Gonadal dysgenesis, and then you can have androgen excess, whether it's from the baby, placental, or mom, and then you have the others. So this is a case we had here. This was a baby that was, the told was a boy. The ultrasound, when the baby was born, had ambiguous genitalia. They did a workup which revealed 46XX. The testosterone was elevated. The 17-hydroxyprogesterone was normal, so there was no and you can see that on one side there was a uterus, and on the other side there was a testicle. So this is what we would have called a true hermaphrodite in the old days. It's an Ovo Testicular DSD. The family was before we had a full team with me and Edgardo Menviel, and we talked about fertility and gender and all such, and the family decided to raise this child as a boy. This is where the peds endo person was very upset that they decided to raise the child as a boy because it was 46XX. But I think it made sense given that there was so much androgen exposure that the baby was so virilized, and performed a laparoscopic left hemihysterectomy, oophorectomy, and hypospadias repair. We have not follow-up on this kid. This kid was a funny-looking kid and never saw genetics. So this was like, we really need a team. The others are androgen excess, and the classic is obviously congenital adrenal hyperplasia. This is one of the babies that Hans operated on. There's the three deficiencies, but the most common is the 21-hydroxylase deficiency. It's autosomal recessive, and it's obviously potentially life-threatening. So anytime you see this, a 46XX that's virilized, you have to make sure that at birth we rule this out, and this we can rule out antepartum now too. Evaluation, just to give you some, there's very little literature out there. There was a paper from Seattle where they looked at 250 cases of DSD. The most common diagnosis they had was congenital adrenal hyperplasia, androgen insensitivity, and mixed gonadal dysgenesis. So that's your 45X, 46X. And a large percentage had no diagnosis. Important to note that in the international DSD registry, greater than 25% of the patients had another condition. So I think this is really important for you guys to know. They either had IUGR or cardiac, renal, or skeletal anomalies or central nervous system disorder. So if you see genitalia, I think you really need to look for other things. This is, I printed this paper, and it's right there. This is a great paper you guys as radiologists to have. It's from the Toronto Sick people, and they came up with a very nice algorithm for how to approach these patients. So if there is other anomalies, then you need to think of, if there's other anomalies, think of chromosomal anomalies and syndromes. If there's no other anomalies, then you want to know their chromosomal status. Are they XX or XY? And then those little lines right before the final tables are, can you see a uterus in utero? And because it makes a big difference, right? Because you have a uterus, there's no MIF or AMH, but if there is a uterus, if there's no uterus, there was AMH, and that completely changes your differential diagnosis. So I apologize that this is so small. I'll make sure that you guys get this paper, but because I think it's really useful, I wanted Dorothy to take a peek at it. But what we're do is the karyotype. We check for SRY gene because you can have a Y chromosome without SRY gene, and then that's those children are raised as females. they're born, uterus we want to know, and then if this is just sort of general principles. If they're 46XX, it's usually the most common is complete congenital hyperplasia. If it's 46XY, more variety, and then there's the sex chromosomes. It was the only study looking at antenatal diagnosis. It was another study from Seattle. They had 34 antenatal, and they report separately on their antenatal. They said most of them had penoscrotal hypostadius with known genetic cause, and then the next most common was CAH. Their recommendation is there further testing for Smith-Lemli-Opitz syndrome in 46XY chromosomes and congenital adrenal hyperplasia in 46X individuals may be considered. However, targeted molecular testing for rare DSD conditions in the absence of a family history of DSD has a low yield. So they really didn't recommend doing a full crazy workup antepartum. And I approached Melissa about this and said, well, should we be testing for WT1? We have all these kids with Fraser syndrome who don't have a lot of other obvious anomalies except for their kidney failure. Should we be doing that? And I think that's a philosophical thing that we'll all have to kind of think about. But I think what most of us can agree on is that antenatal evaluation should consist of a FISH RY for androgen insensitivity syndrome and 5-alpha-reductase. If they're 46XY, we can do the Smith-Lemli-Opitz syndrome mutation check. And if they're 46XX, check for CH. You can do an amniocentesis for 17-hydroxyprogesterone. This whole issue of dexamethasone before 10 weeks, I just hope you guys know that this is very, very, very ethically controversial, and the Endocrine Society recently came out with a statement saying this should only be done in study protocols because basically you're treating a large percentage of babies that are unaffected because you don't know the sex of the baby when you're treating, which is in the first trimester. And so the risk-benefit of this has not been proven, and there has been a lot of advocacy around this. This is a whole landmine. When you meet with these advocates, you're like, you're so scared of saying the wrong thing. Everybody can go crazy. But here's the ultrasound, so sometimes you can see the uterus, and what that paper that I showed you, what they said, and it's in the Ultrasound in Obstetrics and Gynecology, is that if you measure the distance between the rectum and the bladder and it's small versus it's big, you can distinguish whether there's a uterus there or not. So you don't have to necessarily see the uterus, but this distance between the rectum and the bladder helps you identify this. I'd love to see what Dorothy thinks about this in the future. This descriptor that if it's 46XY and the uterus, then you're thinking of gonadal regression syndrome, things like that. If it's 46XY and there's no uterus, then you're thinking of some of these other things like partial androgen insensitivity or 5-alpha-reductase. If it's 46XX and there's a uterus, then you're thinking of some of these other genetic issues, SRY, versus if it's 46XX and no uterus, then you're thinking complete congenital hyperplasia. These large numbers of issues, and then there's tons of cases that we don't know what they have, and that's why DSD-TRN was started. So after they're born, we do the karyotype, we do electrolytes, 17-HP, and then we do testosterone, dihydrotestosterone. It's important to do it right after birth because that's when you have that puberty, so that's when you're able to see if there's these, if the testosterone's elevated, if there is a testosterone to dihydrotestosterone ratio that's elevated, LH, FSH, AMH, and inhibin, and the ultrasound is really, really important.
What about glucose? You said electrolytes, but you need to monitor glucose as well.
So in general, what we're worried about is salt wasting pH, and so glucose is not as important, but that's part of what you check with electrolytes in general. So I'll have glucose checked in so many ways. It's my finding. The one thing that came out of that consensus statement is the fact that these patients should be cared for in a multidisciplinary approach. I don't think anyone's doing a great job at this. We're trying, but we still have a long ways to go. The Board Alliance which is sort of the new advocacy group, and they're part of the DSD-TRN, has a beautiful handbook for parents and a beautiful handbook for physicians. In the physician book, they have a monogram of what to do if you have a baby that's born with ambiguous genitalia. You know, the neonatologist first talks to the baby, or the obstetrician first tells the baby this is not uncommon. We need to figure out what's going on, and then the team kind of meets and examines the baby together and has team meetings. They plan out the workup, rule out speech, and then team meetings, and come and present everything to the patient together. I can tell you that, you know, I had a baby that was born with ambiguous genitalia at the hospital center. I thought that was managed very well. It was really the neonatology team that really led everything, and then I went in and was able to talk to them. They did the whole workup with input from the teams at different sites, because we have monthly team meetings, approach this differently. So on some teams, everybody comes in and meets the baby at the same time or meets mom at the same time. Not many of the places are doing antepartum counseling like we're here. And in some teams, one person comes in. And we've gone back and forth downstairs. We started going in, just having one person have a relationship and have that person coming in, and now we've started all coming in at the same time and then leaving different people alone. So this is not easy to do. You definitely want a mix of people. You want child psychiatry. We have Martine Solage, who does our gender team here. Genetics, we have Evie Leon is our geneticist. Social work, so we have Yvonne Doer, who's our social worker, and Tammy Middleton is our nursing manager. Pete's Endo is Rinku Mira, Pete's GYN is myself, and Pete's Urology is Hans Pohl. We have the full team. We have a psychologist now who's been able to counsel some of our families. Is it perfect? Not yet. We're working on trying to make this the best care for these patients possible. Couple things here, just there's a big difference between gender identity, who you feel you are, just how you behave, sexual orientation. People get very confused about this, and it's influenced by many things. About 70% of DSD patients are happy with their gender assignment. So in general, we think that you know, when we have the nature versus nurture argument, nurture has a big influence, but so does nature. And the big thing is we think there's an effect of testosterone on the brain. We know that for patients with age, have a slightly higher gender dysphoria rate than the general population. You know, that is very difficult to assess because our society has not been very accepting of gender dysphoria patients until recently. So I recently saw a 49-year-old CAH kid who was one of Peter Lee's original patients that he wrote about, who came out as transgender and started testosterone at 49. So I think we may start seeing some shifting in this, but I think in general we have the sense that if there was a lot of testosterone effect, there's some changes. We've definitely seen that with the kids who have normal functioning testes, who have cloacomylase, and who are sensitive to the testosterone. Those kids all have male gender identity, so we have to be very careful. The effect of chromosomes on the brains is less clear because our complete androgen insensitivity patients all have female identity. So very careful. I think we're still learning about this. And this is sort of gender assignment. So our difficult cases are our partial androgen insensitivity, our metal dysgenesis, and our ovo testicular DSD. Those are the really hard ones. So I'm going to do a couple of cases just to test you. And then, I didn't print the paper. I meant to bring it, left it in my desk, that shows how to look for the uterus.
Oh.
From Toronto, okay? But, so we have these are kind of made up. 40-year-old G2P1 at 18 weeks has a cell-free DNA that's 46XY, and has female genitalia. People have cell-free DNA, so they do an amnio, it's 46XY. So what's your differential? So differential, right? So it's basically 46XY, you can have disorders of androgen synthesis, androgen action, or the others don't really matter, but the most likely it's going to be the androgen insensitivity, and we've had about 3 of those. I mean, it's going to have more and more. We got scooped They reported it in the Green Journal as this is happening now, and we have these cases that we never wrote up. 48-year-old, 1 at 18 weeks. The amnio, because of her age, was 46XX. Ultrasound shows normal male. So it's the highest, and that's what you have to rule out. Excess can be fetal, placental, or maternal. And that's it. The network.
Great. Sarah.
That's I'm going to go back and show you the ultrasounds because I'm curious to see. So this paper is from Ultrasound in Obstetrics and Gynecology, and they argue that what you need to do is measure between the rectum and the bladder to see if there's a uterus there or not. And that's helpful because what they advocate is a differential diagnosis based on whether there's a uterus or not. I printed like tons of these, and I left them in my desk.
Okay.
I'll make sure to bring them later.
And maybe something we can also, we're getting axials.
That's a
on
great
all
journal
our
for you.
MRs as well, so we might be able to develop some standards.
Yeah, written by the ultrasound people at Toronto Sick, where they've had a DSD clinic for years now. They've been doing this very well. They have a great social worker there.
If there's anyone out in the community, if they have any questions, you can.
I think callers are two.
If anyone has any questions, they can.
Can we hear them? Is there supposed to hit? Okay.
Okay. Any questions from the group here?
So that was really amazing.
That was wonderful.
And we're really very fortunate to have you as a researcher, you and your team.
Once a year.
You know,
happen more.
as you know, I think everything really comes down to the brain. So
It does.
in terms of how people reproduce themselves, which is really fascinating with the recent race identity issues that have come up in press and these identity issues and sort of quantitative brain analysis of these cases. Are there regions of the brain that are better developed in females than in
So
males?
there have been studies in transsexual individuals, and we see that mostly. Let's just turn that off. There have been cases in transsexual individuals, which are kind of interesting, showing that certain areas are developed more like a male brain in patients who identify in trans males and so forth. But some, that literature very well, and some of that is evolving. But in the DSD patients, nothing's done. But, it's like HIV and transplant. We use HIV as a surrogate for transplant. The same thing for this. I think we're going to use the trans patients sometimes as surrogates for our DSD patients because there's such variety in our DSD patients.
I want to ask, if you look at those that are gender identifying as a different gender from what they have been raised, is it that actually has gone back and then looked to see if in fact they have the order?
Yeah, people always ask that, but I really think that doesn't happen, and this is why, because I take care of a huge group of trans kids. The trans boys are menstruating. You don't menstruate unless you have, have a gonad, that's an ovary, and you have a uterus. And so, there's nothing wrong there if you're menstruating. The same with the trans girls. They're going through male puberty. And so I think from a hormonal point of view or from a genetic DSD type of point of view, that's not the case. Now, there are some twin studies that show higher prevalence of trans in twins, and so or more gender spectrum type things. And so there probably is some genetic influence in that, but we don't understand it very well. But as far as the brain is concerned, there are differences. It's just hard to know. A lot of these studies were done after the patient identified a certain way, so it's hard to know what's sort of how they developed once they've identified a certain way, what's the effect of hormones, and so forth. DSD-TRN have this cadre of patients. It's a little chaotic, I have to admit, but the plan is to have about 800 patients in the registry, and I think there's opportunity within there for different people to have their own research study. Like, I'm interested in looking at gastrectomy in complete androgen insensitivity kids. I want to really do a good prospective study looking at the kids who reach their gonads versus the kids who have them removed, and looking at quality of life measures and, you know, cardiovascular outcomes and screening what works to find these tumors. I think there's room there for somebody who is really interested in doing something like that, but you would have to apply for a grant, but you'd have access to these things, which I think is very interesting.
What do you call it?
DSTRN. So
Do they have good advocacy at the NIH level for funding?
Yeah, so they had a huge grant when they started. Just to give background on the DSD-TRN, it was started by Eric Velen and David Sandberg. Is a geneticist and a psychologist. So that's really a big layer. The other people have not been as good at advocating. They got $500,000. They got a lot of money sort of up front just to create this registry, and they had 4 initial sites, which was Seattle Children's, UCF, University of Michigan, and UCLA. It's now, that's actually an old picture. It's now, we're like 10 sites now. Most of us are unfunded. The funding ran out, and they just applied again, and I don't know what happened. It was reviewed recently. But the idea is within this structure to possibly have different groups or different groups of individuals apply for R01 mechanisms for different studies. So, yeah, they have a contact person at the NIH that they've been talking to. And
with all of this sort of gender identity stuff at the press, and, you know, glad at your checkout at Giant, you'd think that there would sort of be a groundswell of, because it's a fascinating area.
And we don't know very much, and we don't do a good job. I mean, I can tell you I have a kid here that I saw in Vulva Derm Clinic, of all places, a cloacal extrophy kid who, you know, genitalia looks female, has been raised as a female, still has testes in there. Nobody's addressed any of these issues, and this kid's going to go through puberty soon. I mean, it's really very, very difficult. The other team, so we present cases once a month, and the other teams have had all these cases that come in out of care also, and it's really, it sounds beautiful, you know, you have this team, and you have a social worker, and you have a psychologist, but the reality is much messier than it sounds.
Yeah, I'm sure it's a tiger country.
So, yeah.
Thank you.